What about management of Juxta and Thoraco abdominal aortic aneurysm? It's a single center experience. We have a lot of options. These are the options: open surgery, hybrid technique, Shiva, endo-anchors, fenestrated grafts, T-branch, or physician-modified endografts. Here we are talking only about hybrid technique. Why hybrid? Because it has advantages of open surgery, as there is no thoracotomy, with fewer pulmonary complications, fewer cardiac complications, and less pain. There is no hypothermia with subsequent coagulopathy and cardiovascular instability. It's applicable to a wide range of patient anatomy, and there is reduced duration of mesenteric and visceral ischemia, and thus the incidence of acidosis, sepsis, and renal impairment is less. There is less blood loss and less need for blood transfusion, and more patients can be treated where some comorbidities previously excluded them. What about the advantages of over endovascular options? It uses the currently available devices and familiar surgical techniques. It's cheaper. FIVAR needs 6 to 8 weeks to be available, and T-branch is not always available. What about the disadvantages? Technique needs specialized centers with experience in the procedure. It needs long-term follow-up, still significant physiological insult to the patient, and risk of paraplegia theoretically is still high. We are performing it frequently. We usually 2 teams, one for exposure and one for the bypass, because it's a lengthy and tedious operation. Some quick tips: don't use vessel loops. Bypass to the renal artery preferably to be end-to-end, and the proximal end of the renal artery should be ligated and sutured. Orientation of the graft to the SMA and celiac trunk should be C-shaped, and use a external supported graft with a PTFE or DACRA. These are some examples of our patients with transperitoneal and retroperitoneal approaches. Even we can do internal iliac artery transposition if we want to go down to the external iliac artery. And these are examples of post-operative follow-up of these patients. The preliminary results for 100 cases are good. 2% mortality rate, 1% occlusion of the graft to the SMA, which had been treated with mechanical thrombectomy. There is one limb occlusion with fem bypass, and there is no renal impairment, although one case there is an occlusion of the graft to one of the renal arteries. Nowadays, we are doing combination of debranching and Chivar, like this old lady. She had an EVAR 3 months ago for a short neck and angulated neck. 3 months later, she presented to us with an endoleak, Tapani endoleak, which had treated by a cuff and a Chivar to the SMA. And then 1 year later, she presented again with Tapani endoleak due to aneurysmal dilatation above the stent, cuff, and had been treated by bilateral renal debranching, and then we extend the chimney of the SMA and the celiac trunk. Also, we are doing combination of debranching and physician-modified endograft, like this young man who had the Marfan syndrome. He had 3 years ago a repair for the aortic valve and ascending aorta. And on CT scan, we found that the hepatic artery lies separately from the aorta. The patient is refusing totally open repair, and branch device at the time was not supported by the national insurance, and so we decided to go to visceral debranching, and then the second step we proceed with endovascular approach. This is done through 2 pararectal incisions with a bypass from the left external iliac artery to the celiac trunk, to the SME and the left renal artery, and another one from the right external iliac artery to the right renal artery. And 2 days later, an in situ fenestration for the hepatic artery was performed. This is the first angiography, and then we called the splenic artery in order to avoid type 2 in leak, and then partially deployed the Medtronic Valium graft, and through it we cannulated the hepatic trunk, the hepatic artery. And after that, we completely deployed the Medtronic Valium graft, and we ballooned the graft in order to break the tide-reducing sutures, and then we inflated the covered stents into the hepatic artery. And this is the final picture, which was perfect. Combination of debranching and Chivar, we have done very few cases. The results are good. It's very appealing, as the operative time is short and is advantageous to both the patients and to the surgeon. It can be done as as a bailout technique, as in this male, he's 82 years old with all risk factors, and after cannulation, he was planned to have full physician-modified endografts, but after deploying the grafts to the celiac lining of the SMA, the patient became hypothermic and severely acidotic. We aborted the procedure, completely deploying the TVAR graft, but 12 hours later, the patient became anuric and went into an urgent bilateral artery debranching, and the patient had hemodialysis for 3 weeks until the kidney completely recovered. And after 1 week of complete kidney recovery, we go through using ivacin carbon dioxide, covering both renal fenestration and performing the EVA. And this is the final procedure. All grafts are open and there is no endoleak. What about international experience? The systematic review meta-analysis showing that the 30-day mortality is around 10%, paraplegia is around 4%, endoleak is around 20%, and graft patency is around 97%. This is a paper published by Kalpil comparing fenestrated grafts with visceral debranching, and he stated that both techniques are feasible, although fenestrated graft may be associated with lower mortality and morbidity rates. This is a review article, but only central experience with a great variation in number of cases that have been done, with a great variation in the complication rates in each center. But this recent paper in 2023, published by a Chinese group, and they concluded that surgery, this technique is feasible in selected cases. It simplifies the operation procedure and decreases the risk of mortality and morbidity in high-risk patients, and can achieve ideal early clinical efficacy. What about the North American Complex Abdominal Debranching Registry? This has been published in 2011. They included 208 patients, and they showed that 30-day mortality is around 14%, paraplegia rate is around 10%, endoleak around 13%, and graft patency 90% primary and 85% at 1 year. This has been reviewed again in 2022, and the conclusion was that the outcomes of hybrid repair at centers of excellence and in carefully selected patients may be comparable or even better than the traditional open or even totally endovascular approaches. This is another review article about debranching aortic surgery, and they concluded that this technique demands careful planning and surgical expertise in order to reduce mortality and complication. Thank you.